Good afternoon, everyone. My name is Jamie Boudreau. I'm with the Louisiana Mississippi Hospice and Palliative Care Organization, and I want to welcome all of you today to the 10th session of this diving into hospice inside of corrections. Um, Lisa Sigsworth is going to be presenting today, Final Hours. And this will be the last of the ELNEC series, and next week we'll be looking at state minimum standards. Um, in the meantime, I want to remind everybody that if you need to get in touch with any of us, these are our this is our contact information. Feel free to either call or email us with any of the questions that you might have. We want to thank especially the Franciscan Missionaries of Our Lady Health System for sponsoring all of your continuing educational credit that you've been receiving, which brings me to the point that you inside of corrections are automatically members of this organization. And in terms of collecting your continuing education, you have to sign in to the website. First time you can use the temporary password, and then you'll get to redo that once you're inside. It gives you access to a lot of information that the public doesn't have, as well as to all of our member rates, as opposed to non-member rates for educational products and services. And we're looking for folks to sign up to. We would like to create a task force on corrections that will continually look at the way in which we as an organization respond to the needs inside of corrections. Speaking of, we are creating you have to be signed in to get onto this page. But if you're in corrections, you can sign into our website and go to professional resources and click on corrections, and you can get all of these videos that we've been doing each week, all of the download all of the written material and the videos. We're creating just a page just for you to go back and use as a resource in the future, anytime you want. And I want to remind everyone that in order to secure your continuing education credit for today's session, you have to attend, you have to be present, you have to make sure that at the end of today's session, you sign in with your name and your email address. Within 24 hours, we will be sending you an email that will give you access to an evaluation form that you have to complete in order to get the credit and certificate. And all of that stored inside of the website under your profile. So the videos are there for your review. They're not there for folks to get continuing education credit. And having said that, I am finished my introduction, other than to say, Lisa, thank you.
Yes.
Thank you for coming to us from San Antonio, Texas today, and helping us through the final hours of palliative
Thank
care.
you. Thank you. Now I can see if I can get this back on. There we go. Nice. Thank you for joining me today. I'm very honored to be able to present today, and this has been a wonderful session. I hope everybody has gotten what they need out of this. So without further ado, we will head right off into the curriculum for final hours. As a reminder, Jamie will have, we discussed this at the beginning before we kind of started, you will be able to have the slides and the different things coming across. There are going to be in-house videos that are inside that we will not be watching because of time constraints. So we will be running through those, but you will be able to, I think, to have access to them after the program is over. Thanks. So the learning objectives for this is at the completion of this module, you should be able to assess an imminently dying patient and list 5 physical signs and symptoms of the dying process. Assess the physical, psychological, social, and spiritual care needs and interventions for an imminently dying patient and their family. And discuss the role of the nurse, surrounding the death of a patient. Now, this session, the ELNEC session, is geared toward nurses. So whenever we see the nurse part, I want you to be able to put your role into that so that we can alter it, and it gives you the ideas of what you can do and look for during the time when someone's passing away. These are a wonderful guideline for you to use to be able to open you up to be able to experience and work with somebody who is actively dying. The other thing I would like for you to know is that every body is different. And what I mean by everybody, not just everybody, but every body. Your body acts differently. Everybody, according to what their diagnosis is going to go through that end process in a different manner. Now, the National Consensus Project guidelines, the domain caring for the patient near the end of death. Care is provided to the patient and their families near the end of life, with the emphasis on the days leading up to and just after a patient has passed away or toward the passing process. A lot of us like to use the word transition, transitioning between life to death during that time frame where the body is starting to actively go into the stages of death. There's a comprehensive assessment. You want to make sure you're managing the pain and other symptoms so that not only the patient is comfortable, but also those that are witness to this event will also be as comfortable with the process as possible. Education helps someone become more comfortable. It's not that they're going to be completely comfortable at any point, but it becomes knowledge is power on this. Assessment and management of the social, spiritual, and psychological and cultural aspects of care of the patient as they near the transition and going into death. The team provides appropriate education to the patient and family and other caregivers about what to expect near and immediately following a patient's death. As they're getting closer to that transition, your chaplain and your social worker come in to play to make sure that they're there and they're working with everybody so that not only are the physical components taken care of, but also the spiritual and the emotional side. Now, preparing for a good death. What is the role of the team? And I'm going to put, instead of the nurse, just the team. Hydration, do they need it? Do they don't? What's going on? Have they signed a DNR for Louisiana and I think Mississippi also? You have post. There is tell you what their wishes are during the end times. Do they want to have resuscitation? Do they not? Are they wanting IVs? Do they not? What is their wish? Have they asked you to hasten death? Now, most of it, I do believe the ones of us, there's not that many states that have the right to die in place. Louisiana, Mississippi, Texas, Arkansas, these states in this Bible Belt region do not have that in place. So what we will be requesting on this one is that what and why are they asking to hasten their death? Is it because they're in pain? Are they afraid of the symptoms or what's happening? This is a very good video, a good death, and as a reminder, Jamie, and then we'll have the opportunity to give you these informational videos after the sessions are over with so that you can hyperlink in and feel free to be able to watch these wonderful videos. Preparing for death. Everyone dies. We may not know the hour or the time, but we are always in the process of going out of this life. We're born to die. And during that frame, we want to make sure that the patients and the people who are involved with hospice, they've got their advanced care planning in process. What is happening? Do they know? Good planning for a hospice patient would mean that they know exactly what's going to happen. I'm not getting resuscitated. I do not want IVs. I want my family to have certain things. And so this little bitty advanced directive YouTube video is a very good one, which the hyperlink in again later on to be able to watch this. But advanced directives gives everybody around you the opportunity to know what's going on, to know what is the next step. Do they want things left to certain people? Not only that, but who is in charge? One thing that you have to remember too is that who is making the decisions once the person can't make a decision for themselves? Who is the person that they want? Recognizing the transition to active dying from being okay to moving into going past to the active dying stage, caring for the dying, and then post-death care. Now, the staff provide the support for the patient and the families and for other staff members. Interpersonal competence. What is interpersonal competence? Does that just mean that you're competent, that you're smart? Not necessarily. Interpersonal competence is how are you working with and dealing with other people with different thought processes. All of us come to the table at hospice because of the fact that we view death from our perspective. You just have to remember that everybody sitting at the table with you or that's working with you or the person themselves all view death from their perspective. We do not all have the same perspective of death. Even if we have the same religious beliefs and backgrounds, there's still minute things that happen while we're trying to transition and while we're working with somebody in the end stages. Being present. Are you present or are you thinking about what your next person that you have to see or who's cooking dinner or maybe you've got something else that you need to do? So being present is bringing yourself directly into that spot. Bearing witness. Bearing witness is one of the hardest things to do. While you're bearing witness, you're upholding the thoughts and the wishes of the person that is passing away and of their family. And it may not be your belief system and it may not be what you consider to be what's necessary, but you're there to bear witness that you're witnessing them do what they wanted to do according to the way that they wanted to die. The interdisciplinary care comes into play because you have your chaplain, your social worker, your aides who are giving the bath, your family, the medical directors, the nurse practitioners, all coming together to choreograph what is necessary. In one of my earlier presentations, I talked about how important it is that we are the choreographer. We are choreographing the stage and the play that's about to come. The patient themselves are the main actor. They're the ones, and we are putting together the stage in order for them to be comfortable, as pain-free as possible. Their family is involved, and we are choreographing by use of medication, supplies, and equipment the best possible outcome for them during the time that they are being birthed from this life to the next. Let's think, how many of you have actually seen somebody that passed away in a hospice program? I've seen people pass away in different stages in different places. But what went well? Were the patient and their family's wishes honored? Were there any cultural traditions that were needing to be done? Were they honored? Were they not? Was the pain controlled as well as all the other symptoms? And was it evident that the interdisciplinary care was given? Was the chaplain involved? Was the social worker? Was the aide? Was the doctor? Who was involved? What went well? Now think about something else. What issues could have been prevented? Were there any policies or procedures that needed to be developed that would provide a better direction? What could have been done better to have improved the end of life care and the transitional stages of a patient in the active stages of dying? You always want to have open and honest communication, conveying a caring, sensitive, and compassionate approach. Provide information in the simplest terms. You know, when I first started this a long time ago, they told us make sure that you have everything at the 6th grade level. Then they lowered it to fifth grade level. I do believe now it's between 1 and third grade level, to be able to make sure that when you're talking to someone, you use the simplest terms. If you're working with somebody from a different culture, make sure that you understand that certain words may not carry the exact same meaning. For example, I do not speak Spanish. And I used all of our Spanish speaking Google Translate, and I put in what I thought was an absolutely marvelous informational sheet on how they use the anxiety medicine lorazepam and Ativan during a time of anxiety. And I used one of the terms, but I did not know, and neither did Google Translate, that depending on how you're using the language. So what I did was that I used a very simple word, molesta, which means that anxiety. What's happening with them? Well, I didn't use the correct verbiage on there. And so what it's mean was that when mother gets upset, or you're upset with mother, go ahead and take her anxiety medicine. I didn't mean for them to take the anxiety medicine. I meant for them to give their mom the anxiety medicine. Fortunately, we all had a good laugh about it because they did also speak some English in the home. But providing information in the simplest terms is very good. We have Spanish speakers here, but it always goes to show if you're trying to use something, always try to verify what you're saying and use the simplest terms and terms that they understand. Is the patient aware of dying? Many times they are aware of dying. They may not discuss it because they don't want to upset those around them. But maintaining presence and working with them and making sure that while you're working with them and they know that they're dying, that what they're seeing, even though we can't see it, what they're seeing, you can validate for them. I understand that you see your mom and that your mom passed away a long time ago. How are you with this? Are you comfortable? Dementia patients, on the other hand, that does no good to try to reorient in dementia patients during this time frame. So just working with them, are you okay? I understand that you see your mom. And you also may allow them to talk. I want to go home. I'm ready to go home. Okay. When would you like to go home? Sometimes during that end stage, there's actually an awful lot that goes into that. Dying is an individualized personal experience, and there is no typical death. Like I said earlier, every body, your body, every body is different. So there are no typicals. We can tell you what it looks like. The book Gone From My Sight does an absolutely phenomenal job of telling what a physical body looks like during the time frame of an actual dying process. However, it is a typical, and it very, very tells you this is what you see, this is what you see, this is what you see. Sometimes you don't see that. Depends on the diagnosis. What are the patient's preferences? Remember, you're setting the stage. You're going to be an advocate for the patient for the setting and the support process. Psychological and emotional considerations are very important because what goes into their planning stages? What is going on around them? Do they want their cousins in the room or do they not? At the end of death and at the end of your life, going toward the death process, the one thing that's been very helpful is the new phrases and the new upcoming of the death doulas. For many, many years, I talked about, and those of us that's been in hospice for a long time have correlated having a baby with being at the end of your life. You're getting bad news, or you're getting a terminal diagnosis and you're told that your terminal diagnosis. If you think about it, pregnancy is also considered a terminal diagnosis. All it means is there's an endpoint coming. So as you're doing an endpoint, you go to the doctor tells you you're pregnant. And so what do? You go home, you tell your family. And everybody, depending on how they were excited or not, then they start helping you get your house ready. You make plans. You do everything that you need. You go to the doctor or you get ready and you work with your care team in order to be able to give birth to a healthy baby. You go to the doctor and hopefully with good pain management and your symptoms are controlled, at the end of that pregnancy, you are able to birth from this life, from that life into this. You birth the baby. And depending on who's standing there with you is how excited that they are. Does that happen all the time? No, it does not. But at the end of your life and you're given a terminal diagnosis, you go home and you tell your family, I've been given a terminal diagnosis. You immediately start planning and start getting everything together because you've got a lot to do. Because at the very end, hopefully, with good pain management and symptom control, you birth from this life to the next. So the same process, just an opposite direction. Now, there's a lot of discussion about the perceptions of starving to death and do you need IVs and why you won't drink. We correlate, and it's true, life with food and water. And when you can't eat or drink, then of course it becomes very evident that you're not going to live. The body has a miraculous way of trying to shut down the motors and the processes in your body that it doesn't need to survive anymore because it has to move that information to a different spot. In our brain, if you look at it as a computer system, the computer system says, I need more energy sent to the heart and lungs, so I'm going to shut down the motor that runs the stomach. We're not going to do the peristalsis because I see that the heart and the lung need more energy there. So then it slows down. They take food in and the food either comes back up or they have very bad bowel movements and it's moving it out because it's not able to absorb like it was anymore. So the body itself actually starts shutting everything down. I've seen both hydration that worked well and then hydration that sent somebody into congestive heart failure. So it depends on the body. Hydration does not decrease the dry mouth. Like I keep dry mouth. I drink like tea all day long, and I know I'm not supposed to have all the caffeine, but I have just dry, but it's some of my medicines that I'm on myself. So it doesn't necessarily mean that you're hydrated versus with a dry mouth or not. So that can be one of those, it's maybe not a real good indicator. So what are the cultural and ethical implications of withholding the nutrition? In most cultures, food is used not only for nutritional purposes, but it's also a social engagement. We plan almost all of our stuff around food. And over the years, I would laugh, the Southern people, we do this. It's not just Southern people, it's all people. You're going to have a social engagement. There's going to be some kind of food, there's going to be something to drink, there's going to be something there because it's a social engagement that actually helps keep our hands occupied and helps us move in a social gathering in a group. Now, when a patient is no longer interested or able to eat or drink, this causes great anxiety, just like I was just talking about. It's a social interaction. It shows that the person is actually declining. And that is actually where the anticipatory grief kicks in. You're now anticipating, now they're not going to eat, now they're going to start declining. Maintaining the three ethical principles, remember these from earlier: autonomy, beneficence, and non-malfeasance. We do not do any harm. The resuscitation, that means, was there any care planning done? What are the actual unrealistic beliefs regarding survival or the patient's family present during a resuscitation? Having actually done resuscitation on someone, it is not like the movies and it's not like television. There are broken bones. Depending on the person themselves, very few people, I think less than 5%, will actually make it through resuscitation, and it won't be the elderly. Their bones are much brittler. It's depending on how long they've actually been unconscious and without any no heart rate and no breathing. Your survival rate for anything like that is very, very low. And once they've already started stepping out and they do step out, then resuscitating them is more for the family. And it's very difficult for them to watch because they literally are thinking that it has a lot to do with what they saw on television. They've never actually seen it in process. Pacemakers and cardiac resynchronization therapy needs to be looked at prior to somebody passing away. They need to make sure if they've got the implanted cardiac defibrillators that somebody knows something about it at the LVAD. We're going to go to the LVAD in just a second, but we're going to stay on the pacemakers real quick. It's important that they know that these to be cut off because it will continue to shock the body. There have been lawsuits from family members because of the fact that they sat there thinking that their person was um, dying appropriately and was going to pass away, and the defibrillator was not cut off, and it did send shock waves to the body and a mild shock wave through the side of the bed. So you have to make sure that those are all cut off prior to that. The LVADs, are an external device that are helping to make sure that you have your heart rate is going, and it actually is an external pacemaker. These are actually only good for about 5 years, give or take, with the battery. And so you need to know what the process is if you decide to have somebody on an LVAD, because there's a lot of medication that goes into that. You have to make sure that they're comfortable, because once the battery runs out, they're going to have a massive heart attack. So you need to make sure that you've got a real good policy and procedure in place to make sure that they're comfortable and that everybody in the room knows about it. LVADs also are reused sometimes, so you have to get with the hospital about what their extubation part is on that, because it's actually stitched into the chest. Inotropes increase the cardiac, these are all medications, okay? So we'll go through these because a lot of you won't actually have to deal with these, but you may have to talk to a family. There are certain medications that help the body and the heart to function. It helps the heart to go like this. And so as it's going like this, some of them are on this side, some of them are on this side, but in together, they're doing this. So if you stop it abruptly, then you're going to have one side doing this and one side going that. It's not going to be comfortable. So you have to get with the doctor in order to make sure that you have a correct decrease of the medication to slowly allow their body to adjust down. You want to make sure that you preload them with pain and symptom managements, because the perfusion for their heart is going to be very, very poor once those drugs are maintained and taken off. So you need to make sure that you have enough on there. A lot of the home hospices will not accept these or the LVADs. And so if the enrollment, or that's something that you're going to look for inside of corrections, then you need to make sure that you've got your cardiologist on board to be able to map out a good plan for them to pull them off. If they've got an LVAD and they're going to keep them in your facility, I would suggest also getting a screen. I don't know if you have an open plan area for your hospice. I know Angola's was open air with a bunch of, your things. You want to maintain some privacy there, because it's going to be hard for them to other people to see. That's what I'm getting at. So you want to make sure that you have them divided off away from general population and away from other people, so that once that starts happening, then you're able to maintain dignity for them, but also dignity for those around them. Now, discontinuing withdrawing mechanical ventilation, I'm pretty sure that you won't have to worry with this one too much. There are medications that need to be given during a time frame when you're withdrawing somebody off of a ventilator, to make sure that they're comfortable. Are you going to withdraw and take the vent completely out of them, or are you just going to turn off the oxygen going to it and the vent themselves? So there becomes the way, is it inside? Are you looking at a trach? So there's several different things. Policy and procedure. You want to make sure that your advanced preparation, you pre-medicated, and how are you going to do it? Is it an immediate extubation, or are you just going to wean them down? Dialysis. When should dialysis be discontinued? The burdens outweigh the benefits, or when dialysis is no longer providing life and only prolonging the death of somebody. I think the longest that I've seen somebody go without dialysis was around 30 days, which is kind of a long time. If they've been getting dialysis 3 times a week and they're in there from 4 to 6 hours, the swelling and the increase of the poisons in their system will cause increased confusion. Their heart will be overwhelmed along with their system, and they'll usually slip out into a coma and then go into death. But it is something that needs to be. Hospice programs, FYI, if you're outside of the corrections facility, hospice cannot be done at the same time with dialysis. It doesn't matter what your diagnosis is, CMS is not going to cover it. So that is something that needs to be discussed. Organ and tissue donation regulations, talking to the family about organ and tissue, what can be donated. Normally on a hospice patient, it's just about anything that's okay with if it can be taken off of a body that's passed away. During hospice, but the end, they would need to go to the hospital to be an organ or tissue donation. Most hospice patients are not eligible for hospice other than the eyes, and the eye ladies are very happy to talk to you about that. Now, request for medical aid in dying. This is the right to die. Interventions to cause death more immediately than if an illness took its natural course. Was there a statement made by the patient that they wanted to pass away faster than normal? Is it a progressively incurable illness such as Lou Gehrig's or ALS patients? Huntington's disease. Judgment is not impaired, and the medications must be administered by the patient. Having traveled around to Oregon and the different states that do have the right to die, the medications that they use, they have to give it to the patient, but then they have to be off of the premises. They have to be off, they can't be on the land. If you're at their house, they got to go out in the street. They can't be actually on your property during that time frame, and the patient has to have the ability to give it to themselves. They have to do the shot, they have to do the pills, they have to do it themselves. Nobody else can do that. The nurse needs to assess the context for the request for medical aid. Why are they doing it? What is the patient's decisional capacity and understanding? Do they understand what they're asking for? And also, what are their goals of care? Now, for us that are not and do not live in states that allow for right to die, what happens here is that we need to explore with them, why are they asking for this? Is it because they're scared to hurt? Is their symptoms not being managed? Maybe it's something that we need to look at for terminal sedation. That means that you keep someone out until they pass away. You don't give them enough to make them pass away, but you give them enough to keep them comfortable to the point of where they're asleep or they're not going to wake back up. Back in the 90s, I lived in Arkansas, and we had the most wonderful man who was our pharmacist at the hospice. And he found out that he had gastric cancer, and he knew what was coming. It was going to be short, was very painful, and everything was already involved by the time they found it. And he asked us for to keep him terminally sedated, and that was the first person I had ever worked with terminal sedation. One of the nurses had gone out, and when she went out there, she didn't give him the normal dose and had it set up. And so he woke up and he was very angry. He said, "Please do not do this. I no longer want to be awake. I want to stay in a sleep-like state." So we had to actually make sure that the medications were titrated to keep him in a sleep state, not in a death state. It was very interesting. I've not done that but maybe twice out of 32 years. Now, psychosocial changes, we only die once. Unless you've had somebody that's had an NDE and near-death experience and they've been brought back. What is it about dying that makes us so afraid? Is it the feeling of loss? At the end of life, the patients may become more introspective if they're able to. What are they allowing and what would they no longer want? Are they wanting to talk to somebody about getting and unloading a lot of information? What was happening during that? Are they afraid to die? What I have found is that sometimes the Christian belief system and the ones, the Abrahamic, are a little more afraid to die than your Hindu or your other, the ones who believe in reincarnation. And I think that's because they want to make sure that if they ask Jesus to forgive them or they ask for forgiveness, they want to make sure that everything's okay. So they're afraid that they may have forgotten to talk about something or what's happening out there. Did they mess up somewhere that's going to keep them from going on? Is it the fear of loss? We also have a tendency to forget that we are so tied up with our grief and what's happening that we fail to remember that that person's losing everything that they know to be a fact. Are we able, and what are we seeing? We don't know. We're about to find out that if everything that we believed in, we're about to find out if it's really going to be there. Because once you cross over and you do that, that's a feeling of loss. The people are tied up in their grief. They sometimes forget that that person dying is about to make a journey that we can't go on with them. They're about to cross over and they're losing everything that they know to be a fact. They know that you're here. They know that they're in their bed. They know what's going on around here. But they're about to cross into a realm that they're really a little bit unsure about. Then when they start slipping into a coma, then the introspection becomes more along the lines with the family and not the patient themselves. Spiritual considerations when death is imminent. Whoop. I don't know what happened here. Well, okay. Let me go back into this. Ah. Oh. Okay. Let's see. I apologize. I'm trying to get um okay. Where
The little screen at the bottom of your slide.
Okay, that's what I'm looking for down there. It usually has it way up here. I don't want to put a new slide in. Okay. All right. So the two roads to death, we have normal, restless, confusion, tremulous, hallucinations, mumbling, delirium, and myoclonic jerks. When there may be also, you'll say maybe see picking and jerking. How many of you have ever gone to sleep or you're about to go to sleep and then all of a sudden you jerk, your legs jerk, something happens? That's also called a myoclonic jerk, by the way. Um, then you also have normal, which is sleepy, lethargic, obtunded, which means that they're out of it, semi-comatose, comatose, and then they've passed away. But if you'll notice, either way, the upper region, the difficult, or the lower, all come from seizures, obtunded to semi-comatose, comatose, and then where they passed away. A lot of times at the end, you'll see confusion, disorientation, delirium versus unconsciousness. So if they're delusional and delirium, we usually will give them some type of anxiety medication, weakness and fatigue versus that surge of energy. At the signs around 7 days, 5 to 7 days prior to someone dying, they'll usually get a surge of energy. I've seen it go anywhere from they woke up and they actually recognized people in the room to where they actually got out of bed and were cleaning the house. So it can go from something very minor. It doesn't have to be the big thing where they're getting up and their family hasn't seen them out of bed in years, and all of a sudden they got in there and grandma's in the kitchen trying to cook dinner. It can go from that all the way down to literally just opening their eyes, looking around, and seeing somebody and recognizing them and saying hi. Can go from very minor to large. Drowsiness and sleeping versus restlessness and agitation, that's going to be accordingly a medication that you're using to keep somebody comfortable. The physical considerations is that fevers, sepsis, and different tumors run a fever. You're going to have bowel changes right before somebody passes away. literally right before they pass away. Their rectal sphincter will usually open up and there'll be a large bowel movement where everything will just release along with their urine. It just relaxes. It's a relaxation of the sphincters in the body, which is part of their incontinence. They're going to have a decreased intake. Now, the most common symptoms in the final days and weeks of life are shortness of breath, pain, maybe that noisy breathing and respiratory congestion that you get. That's also called the death rattle. We can use atropine drops or certain things that we can use to try to lower that, but it's more for the comfort of the family instead of the patient. Because during that time frame when they're starting in with the death rattle, they're not as uncomfortable as we perceive them to be, because it's more alarming to us and to the family. So a lot of times we'll give them that, and they'll also forget to breathe. That is called the Cheyne-Stokes respiration. They'll forget to breathe, and all of a sudden their body and then they'll start breathing again. Some other symptoms to be aware of near the end of life is delusions of delirium, the myoclonic jerk, seeing people who are not there, but they can see them. Just because they can see them and we don't does not mean that they're not actually seeing somebody. So I try to make sure that the family understands and those around them understand we don't know what they see. I'm not about to tell them and argue with somebody at that point. That's wonderful. It's okay. Do you see the angels? If you see the angels, do you hear singing? And so allow them to open-ended conversation to allow them to be comfortable during that time frame. Hospice does use opioids during the final days and hours, and it's based on the appropriate assessment to be able to see what's going on with them, and that dose may be decreased or increased. We can use, let me check my time frame. Jamie, make sure you wave at me when I'm getting closer. The dosing may be decreased or increased. Some people we use a lot less toward the end because they're not necessarily needing it because their spirit is starting to step out of the body. We also use other routes than oral. Medications can be given rectally or sub-Q. The medication can also be given in a cream form to be able to, ABH cream, to be able to help somebody with agitation and to keep them calm. Morphines can be given not only in suppository form, it can a very high concentration right here. To be able to absorb into the body. I have used it also in inhalation to be able to get into the system depending on what their diagnosis is. You want to make sure that you titrate them to comfort. That keeps you legal with the DEA. You keep them comfortable, but don't go them too much or too little. You also want to make sure that you recognize and treat any toxicities. That would be your benzodiazepines to make sure that you're not having too much of that in the system. Let the families know that the higher the medication to be able to keep them comfortable may also keep them in a lowered state of consciousness. That's at LOC. The lowered state of consciousness means more sleepy and sleeping more along those lines. Using the dose conversions, if you're working with your nurse there in the corrections, let them know, hey, I see that it seems to be jerking a lot more. Maybe they might need something. And then making sure that you keep an open communication with the staff so that you see that what's going on. Is it a medication for anxiety versus is it something for pain? Sedation for uncontrolled symptoms and palliative sedation is what I talked about earlier. These are the last ditch efforts to keep somebody comfortable, especially if they have certain types of cancers. I think the worst one I've ever seen was a lady had cancer in her nose and sinuses, and it had eaten a hole all through here into her brain, and she was screaming. So we wound up having to make sure that we gave her an awful lot of medication to keep her comfortable until she was able to pass away. Now, some of the symptoms of imminent death would be they're unable to urinate. Maybe you'll see that their body is starting to get cold and mottled, as your family's potty colored. In African Americans, it'll be a little more darker under here elbows, behind the knees. You're going to see a changing to a greeny blue color in some people, a paleness from here, unless they've got Raynaud's. If they got Raynaud's, they're going to be from here up. It's going to be white anyway, but it's a difference in the color from here up. Your nail beds. Now, if you've had COVID, the little round thing right here is going to be a pinky color anyway, because we lose some of that little round white thing right here. So you're going to see a little more here of a discoloration from here to here of purple. Your tips of your fingers may be purple in the webbing of your fingers, and underneath anything that's laying down, the dependent under here. So if they're laying down, you may notice a different coloration of here. Of course, their vital signs and their breathing is going to start changing. You may see some increased confusion or restlessness, may be picking in the air. And then you have the death vigil, where you have somebody with them to make sure that somebody notices when they take their last breath. And the common fears are usually not the patient anymore, but it's the family. What's going to happen? What's next? What are we seeing here? Maybe in the corrections you have someone that's sitting with them. You want to make sure that they're okay and they know what's going to happen. You may notice that they're going to stop breathing. Sometimes the patient themselves will just, when they're left alone, then they'll exit. And so it's common to hear, I just left for a moment. I don't know what happened. They were fine, and I left the room, and I came back, and they're no longer breathing, and I don't know what happened. Maybe I shouldn't have left to go to the bathroom. Maybe maybe it was something that I did. It wasn't. The family and the patient himself or herself decided that was their best exit time. And so they chose that opportunity, their body, to just go ahead and exit out. And it becomes something that, a lot of them don't understand, but it's always a great comfort to be able to let them know that, huh, on the third one. Jamie, this was also one of the other ones. That was a little bit, this one is the newer one, so it's got all of the different sections in it. So you want to make sure that you tell everybody and they know what's going on, because knowledge is power. And you always let them know when they get finished, and don't worry about making phone calls. I'm going to make phone calls. Would you like to help me clean them up? Some people do, some people don't. I've been asked, can you give them a bath? I don't want them to leave this house being dirty. And so I've given full baths, changed clothes, everything that you could imagine during the end, to make sure that the dignity of the patient and the dignity of the family was maintained. Now, after someone passes away, we in hospice move them into bereavement care. Care after death would be communicating with the family and preparing them for the next step, and that's the technical task that happens. The technical tasks are the nurse or or who's there, making the phone calls, making the arrangements. Where do they go? Hopefully, they've already had a funeral home, or you already know where they're going to go after this. Preparing them for those next steps. This is what we're going to do. I'm going to allow you to know that this is what the choreography happens. Care and respect of the body. You need to also know what their religious background is, and if there's any rituals that need to be attended to. Allow the family to help you take care of them if they want to. Always ask, I'm going to be cleaning them up. You can stay with me and help me, or I can do this. You let me know what you're comfortable with. Because some people want to do their hair, some people want to wash their face, some people don't want to be in the room at all. It depends on them. If there's rituals involved, you need to know, that's why it's important to know, are they Jewish? Are they Muslim? Are they Hindu? What are you looking at? You need to be familiar with the rituals that go into what happens after someone passes away. And it's important to know that the family knows that you're comfortable with those rituals. Because if they get to the point where they think you're not comfortable with their rituals or are judging them, it may actually put a kind of a stop on what's happening. So it's always important that all staff members know what's going on and what would be expected. This is a very good one. This is patient's humanity after death has been declared, and this one goes into a little more, and it's more along the lines of not in a home setting, but in a facility setting. The bereavement support is extremely important. Follow up with the staff. If you've had somebody that's been with you for a very long time in corrections, and the staff members know what is going on and they've been with them, staff support is very important. Making sure that you've got something in place for them to debrief themselves. How are they feeling? How are the people that's working with them? Are they okay? Putting something together for them is very vital for the longevity of your programs. Death of a parent, remembering the children, making sure that the children and the developmental stages of those children being open and communicating according to their thought process and how they're doing. You need to know if they're autistic. You need to know if there's developmental delays. You need to know what developmental stage that they're in. Are they like Bugs Bunny? They think that they're going to come right back. Making sure that we don't use the word, oh, they just went to sleep. You don't want to there are words that affect later on, and our words are powerful. So as we are telling them, what we do in hospice doesn't just affect one generation, it affects generations to come. So those generations down the road will remember what's happened during this time frame. Let it always be the most positive thing that you could do for them. Will you always have a positive experience? Absolutely not. But we want to do the best that we can for the people that we're taking care of. Family members will always remember the last days, hours, and minutes of their loved one's life, and they're going to replay it in their head. And the nurses and staff, you have the unique opportunity to be invited to be able to be with them during this time frame. The choreography and stuff that you put into play and how you work with them will live on beyond what you're there for. Again, this is my third one on there. I want to thank each and every one of you for listening to me talk today. And if you have any questions, we're here to talk.
Thank you, Lisa. Yes. I was going to say your volunteers are going to be witnessing the type of care that is being provided in each one of your facilities. Those will be lasting memories that they take with them and also communicate with the rest of the general population. So what happens in your hospice is going to remunerate throughout your entire campus. Don, I was just wondering when Lisa was talking about the whole notion of or not the notion, but the idea of trying to balance comfort with consciousness. You with opioid using opioids and such. Do do people at VitaCore have a sense of how to have that conversation with the individual in terms of what their level of comfort will mean at the end of life? You know, do they want to be more conscious or do they want to be more comfortable when that is, conflicting?
Jamie, I think that I know that is a conversation we are going to have. It's a conversation that we'll need to have with the site medical director. I'm not especially concerned about whether or not the clinical staff is going to be able to handle that, as I want to make sure that the volunteers who are around providing care understand this is how this works, this is how this operates. Because many of them, I would wager to say that many of them, this is going to be a new experience for them. And I know that I saw it in the free world when we had new staff that came in, and it was the first death, the second death. that they had actually participated in. And, I think, uh, and I think you made a very, very strong point, is that what those volunteers carry away from that process is going to have a tremendous impact on the acceptance and the support we get for this end of life care program throughout the entire facility. I think that's going to make or break the.
That's what we're seeing happening on every campus where hospice is there. The grapevine tells exactly what they witnessed, and it either gives comfort or gives fear, brings fear. Luckily, it's been bringing a lot of peace to the campuses that have brought hospice there, knowing that people actually are caring and that these are actually sacred moments, not only for the patient and the patient's family, but also for the volunteers and the entire hospice staff. So, people recognize authenticity, and they're also keenly aware of fraud. You can't fake hospice. If you're faking hospice, then we ask you to find something else to do. Hospice is not for everyone. And it's not for everyone, on the patient side as well as on the professional side. Hospice is not for everyone, but we want to make sure that the ones who are participating in the hospice experience or experiencing an authentic event.
I think you're 100% spot on.
Mhm.
If you've got somebody there who's just going through the motions,
Right.
that's going to be identified very, very quickly.
Yep. And
Really,
your volunteers will recognize it, and your staff will recognize it as well.
you're in tune and you're in the moment. If you are present, uh, that's going to be identified very quickly.
I often tell people the big thing about hospice is that these are people who actually are present. They show up. They're not trying to get out of being around people dying. They're trying to be there for people who are dying, and to celebrate that, and to make sure that those folks have as the send. We only get to go through this one time, and everybody has to do it themselves, and we want to make sure that they're doing it themselves. That that we're following their wishes. So
I think the important thing that goes along with that as well is the debrief afterward. Taking the time to sit down with all of your staff, all of your volunteers who were participating, and pulling from them, what did you take from this? What could we have done better? Where were our strong suits? And how can we make this be the best that it can be?
you don't pull this volunteer corps and the hospice staff is not something you pull together only when someone is enrolled into the program. This is an ongoing program. This is we're constantly in-servicing folks around hospice values, and so even when you don't have a patient, you can still talk about good care, end of life care, good palliative care, what's helpful and what's not being helpful. And you're going to find that it's going to go in all sorts of directions, whether we're talking about medicine or nursing or caring or volunteering or security or whatever the case may be. There are always things that we can use to improve the care that we're providing to the next patient. I'm really excited that we're coming toward the end of this program. We have one more program next week, and we're going to be talking about state standards, because one of the most important things I think that hospices, especially inside of corrections, can prove is that you're meeting the community standards. That there's no difference between, well, there is a difference between the hospice that's being provided inside of corrections and the hospice that's being provided inside on the outside in the free world. And folks, from what I see inside of corrections, folks are getting a much better hospice experience because it's much more controlled in a lot of ways, but the people are meeting the community standards inside of corrections, and exceeding that. So I wanted, sorry, go ahead.
And one of the things I think that is so important, and we fight this every day in corrections, and that's the perception by the public that somehow the care that is provided behind the wire is less than.
Right, right.
That's not the case that I have found.
Mhm.
It's just like any place else. You got some people who are more capable, some people who are less capable, but under no circumstances do we want that transition experience for this inmate to be anything less than what it would have been if they had been in the free world.
Well, we have a long and bloody history that we've been working for the past 50 years to try and correct, and things like hospice inside of corrections takes us a little bit closer to correcting for injustices and historical incidents of the past. So that's all we can do today. I want to thank everybody. I want to remind everybody we're still working out the details for the June 12th visit to Angola. Don, we have a meeting tomorrow morning with Angola to run through some of those schedules. So you'll be getting more and more details as we get closer and closer to June 12th. We really looking forward to everyone participating in that event. If you would be so kind right now as to go into the chat box and type in your name and your email address, we'll go ahead and start capturing that. And Lisa, thank you again for leading us through the final hours of what all of us will eventually see, whether we're in hospice or not. Eventually, all of us get to go through that turnstile. Any questions from anyone that's on today's call?
No, but I noticed something on there, Jamie. I was trying to type mine in and it's going into like direct messages. I don't know why.
Let me see. Yeah, make sure you're doing it to everybody, or
Yeah.
to at least to me, so I can capture your name.
Mine keeps going to, okay, let me just put it to you. All right, there we go. It's going to Miss Franklin, Cynthia Franklin. I just kept reverting over to her name. Sorry.
Go figure. Let's see. Things I see. Things are coming through.
Okay.
Lisa, you just came through.
Yeah. Well, mine was going directly to her, so it was funny.
Okay.
I don't know why.
So if you've signed in, then you can sign out right now. Thank you all for your attention, and we look forward to seeing you next week. Next week's session is 1 hour. We'll start at 1:30, and Miss Ann Walker will be joining us to do state licensing minimum standards for Mississippi and Louisiana. Take care.
Thank you. Thank you.